Welcome to the Healthy Communities Collaborative for America, connecting communities of solutions seeking synergy and alignment. The Healthy Communities Collaborative for America is facilitated by the Health Futures Group. I'm Michael Knowles with the Health Futures Group. We're a network of leaders across the United States health services, including the DoD, HHS, VA, and Public Health Service, inspired by a vision of health as a national strategic imperative. Join us today in an epic campaign for national health, wellness, and resilience. We're going to have four best practice communities of solution joining us today with short presentations interspersed with opportunities for dialogue. Look at your GoToWebinar control panel. You can use the question box to post questions, comments, and share links and resources. The microphones are muted by default so we don't have any background noise. If you want to speak, use raise your hand, use the raise your hand feature. We'll be doing a recording of the webinar, and we'll be sharing that online. We'll send you the link once the webinar is complete. Slides, interactive resources, and continuing dialogue online is going to be happening between events via max.omb.gov and maxhealth.us. At the end of the webinar, we'll give you further information about how to get on there if you're not. Without further ado, I'd like to bring in my colleague, Dr. Mark Loafman, also with the Health Futures Group. Mark?
Thanks, Michael. Thanks, everybody, for joining us and for helping us get started here today. This promises to be a fast-paced, action-packed journey. We're going to spend just a few minutes reframing and setting us back up to get started where we left off from our last webinar, and for those who were not part of that to catch them up as well. But we're gonna be cruising, so I hope you're ready for an action-packed adventure here. So for today's webinar, we're really going to move forward with the roundtable number 3, call to action. And for those of you who were there, you remember that led with a call for an epic campaign, and we're going to review that aim statement in just a minute. The Healthy Communities Collaborative for America really is serving as a launching pad to launch that initiative. We're bringing forward today 4 communities of solution to share their stories of resilience building innovation. So these are really exciting innovations, and we want you to listen to those, imagining what it would be like if the whole of nation, and think even about beyond our borders, that we begin to export that for global engagement. But imagine that if the whole of nation and our global partners were able to appreciate the benefits that these communities have evolved to. So don't think of them as isolated examples, but of what it would look like, the synergy, alignment, and making connections. That's the way we're going to be engaged. And that's an aspiration that we have. It's come from the Health Futures Group and the work done there over several years, building local, national, and global resilience. And we want to be reminded that the style of this work is all about being net forward. So we can spend hours celebrating the problems, and that's not why we're here. But we're thinking about what can be done. We're looking at things that can be done and how to move forward. So that's it. We always want to have a chance to do active listening so that we forward our work with questions to run on. So as you listen, we're going to be stopping and processing, and I want you to be engaged in this. What breakthroughs and innovations are you hearing in terms of moving the nation from healthcare to health? So we want to look at this health and resilience goal and aim as the right next step. As you hear these breakthroughs and innovations, we want to prioritize and pull out those that are ready for scale up. Again, thinking of our nation and our global partners really as being in harm's way, and now we see some solutions that can take them out of harm's way. That's the urgency we need to move forward. We're going to wrap up today thinking about what offers and requests do we have to partner and help these communities of solution reach the scale up that our nation and our global partners need. And then, of course, what can I do by next Tuesday to be in action? So we really want to not just leave with our head full of ideas, but leave with action plans. We sent a worksheet around. We're going to be coming back to this several times. It has our questions to run in, running down the left column, and you can see our 4 communities of solutions, our exemplars up top. As the yellow box at the bottom says, you can make your notes right on this form, and or you can use the GoToWebinar question box that Michael showed you earlier and type your questions in. We have people on the call from all over the country and across the continent as well, in Germany and in London. So, we're not having an open mic all the way around, but there are ways to communicate, and there will be time for each of you to weigh in if you're ready to do so. Real quick recap, and then we're going to get right into meeting our communities of solution. So why are we here? Well, as we said, there's multiple epidemic scale crises across many levels happening all at the same time. It affects individuals and their families, it's affecting our communities, and it's affecting the nation. The lack of resilience is threatening our security and our capacity to respond. That led to a vision, to create a vision. A vision that the Health Futures group sort of led out of this last Health Roundtable, creating a secure, prosperous, and economically stable nation through optimal health and well-being. A whole-of-nation enterprise became the national security imperative, health and resilience now. And what we also realize, it's really a global health imperative to do that as well. So wrapping this section up, I want to just say and remind us that the scope and scale of this really seems beyond control. So our typical solutions have not been able to attack it at this level. And as we know, we've talked about the wicked problems, the problems that are so amorphous and huge and cross-jurisdictional. We've also talked about the enterprise scale. It's really the public and private. And what we know is that the status quo, the way to disseminate best practices now, it just has not been working. That led to this vision of an epic campaign that communities of solution would work in parallel to roll up these best practices and spread them at all levels. And this is our aim statement in big, bold letters here. By 2020, every community will know the level of resilience for each locally prioritized health determinant and be engaged with its leaders, achieving these green zones of success. That's what it looks like. So this is the community of solution. It's an exemplar. It's well, strong, and resilient. It's thriving. It's green zone meters pegged. Thinking of us serving as a launching pad to collaborate to spread these ideas right alongside these exemplars are many, many communities where resilience is wiped out. So this acorn, this seed of knowledge, really can be planted and nurtured and grown, and that's really our goal. With us today are 4 such leaders, communities of solution. We have the Healthy Base Initiative, the Alliance for Integrated Medication Management Collaborative, the Healthy Weight Collaborative, and then the Beach Project out of San Diego. So we're going to jump right in and get acquainted and hear a little bit. So we have tasked our speakers with 5 minutes to tell us what rocks about their program. So what makes it innovative inside of it. And we're going to start with the Healthy Base Initiative. We're going to start with Captain Kimberly Elenberg, who's calling in from Germany. And Michael, I hope we can get her on the line. I'm going to pace through her slides, and I'm going to keep us moving, trying to keep us on the 5 to 6 minute range. So do we have Kimberly up and running and ready to speak?
Kimberly has not been able to join us yet. Mark, can we move to?
Let's jump ahead to the AIM Collaborative. I know Todd and Kathy are with us, so we'll come back to that. So let's jump ahead to the AIM Collaborative, and we'll call up Dr. Todd Sorensen from Minnesota, and then Kathy Baldwin, my colleague, is going to be joining us in a moment as well. So Todd, if you're ready, I can run you through your slides. Can you jump in and say hi?
All right. Everybody can hear me?
That sounds great, Todd.
All right. Thanks, Mark. Yes, I'm here to represent the Alliance for Integrated Medication Management. I'm glad that Kathy Baldwin, one of our faculty co-leads, is also able to join this call. In just our short period of time here, I want to give you a quick overview of the why we exist and a little bit of the how we work and how that might tie into the work of this national effort that's being presented here. So, not to any surprise of anyone on this call, I'm sure, but the prevalence of chronic disease in our country and beyond, of course, is significant. And when we look at that, it's really created a significant amount of extra expense in our systems. Adverse drug events in particular, when you go back to the Institute for, a study in the early 2000s that looked at harms that were created in our health system, it was projected that for every dollar we spend on medication use for chronic illness in the outpatient setting, is creating another dollar of expense fixing the problems those medications have created. So there's certainly a harm issue there, and that's on top of the expense that we see associated with uncontrolled chronic illness in the United States. So, the number of patients that are experiencing uncontrolled chronic disease are in the millions. And as you see here, it's estimated that nearly 70% of our healthcare costs are directly attributed to that. Now, when we're talking about chronic illnesses, of course, one of the most significant and most common interventions to try to help achieve health in chronic illness is medication use. And so coming together in teams to healthcare teams to provide integrated care to address this is really what we're all about. Now, we've been doing this for quite some time, and there's been a number of different studies that have looked at what happens when we actually can do a better job of managing medication use in chronically ill patients. And there is a significant return on investment. For every dollar that we invest in medication management services, when we do this in a comprehensive way, in a systematic way, and in a team-based way, we can generate somewhere around $12 in savings. That's one study. There's been many other studies that have done this, and of course, depending on the population that you're looking at with this, these studies come in between $4 per dollar invested, $4 of savings, up to something a little higher than 12. But on typical average, it's between $8 and $12 has been replicated in multiple studies when you do this in a high-risk group of patients, a chronically ill group of patients, and using this comprehensive model. So when we focus on comprehensive integrated medication management, we can save lives, we can save money, and we get to this, what Mark was talking about earlier, of really getting to resilience in our communities, in our health system. However, as it stands today, this is not a common element of how we deliver health care in this country, and that's what we're, through our collaborative, working to change. You might be familiar with the concept of disruptive innovation if you look in the business environment, and something that is really the market leader. If it's something that's complicated, expensive, or hard to use, that technology gets disrupted when someone else can come in and provide an alternative product that's simple, inexpensive, and convenient to use. Well, we see the same situation going on with medication use, that too often in our health systems, medication use is uncoordinated, it's expensive, it's confusing, and frequently it's unsafe. And when we interject an integrated medication management approach to the care team, we're able to take that and disrupt what we see commonly and create medication use that's effective, safe, convenient, and delivers value to patients and payers. And that's really what we're trying to achieve here, is to generate value in the system, which we're often paying for something that we're not actually able to achieve. Now, Kathy's going to spend a little bit more time when she comes on here giving an overview of how this model works. But with this slide, I just want to briefly say that we've taken our cues from the Institute for Healthcare Improvement, and it's actually quite timely we're doing this. I'm at an IHI meeting today focused on population management, taking time out to share how we're adopting that model and adapting it into our work focused on medication use. So we have teams, and a team is really community-based. It's a healthcare provider team, but it also might be in collaboration with other community partners. And we've got hundreds of those teams actually in action across the country. When an organization enrolls with us, when the team enrolls with us, we get them up to speed with some pre-work, and then we have a number of tools that we use to support them over time to provide education through webinars or live meetings or other types of events. And in between those events, we have action periods where they go back into their own organizations and they apply this performance improvement model, applying plan, do, study, act cycles, measuring their performance, selecting the things that work, discarding the things that don't, and really identifying in how they can expand this work to an entire population. And we bring a lot of expertise across our faculty, our coaches, to support these communities that are in action around improving medication use and health outcomes. Go to the next slide, Mark. And one of the real important tenets of this work is that too often organizations or communities will try to really bite off more than they can chew to start with, and they have a big build-up phase, and they really try to implement and then find out after a significant period of time that they've not been able to move the needle on whatever they're trying to change. We reverse that. And applying that IHI model, we start with smaller groups. So in this case, you might have a population that's in the hundreds of thousands, but there's actually a smaller group that's the population of care that's being served by an organization, and a smaller group of patients that meet the definition of the service that should be delivered, and then taking those that are not at goal and that forms our population of focus. So taking a small number there, and that red box is really getting to where we start with these organizations, and then defining that population of focus, finding that they can make a difference on them, measuring that difference, and expanding out further through these additional boxes once they've found out what works and how to apply it. So population of focus then scaled up to meet the entire population. And the last slide I'll leave you with before turning it over to Kathy is that I found this particular quote from Aristotle pretty timely, that often we feel like our work is sequential, that we need to think and plan and know what to do and then go out and do it. But often we don't know what we need to do, and we can only find it through a process of discovery. And this quote kind of really summarizes the work that we're doing, that when our organizations join us in this effort, they don't know what's going to work, but they have to explore, they need to test, and then they need to replicate the things that do work. So for the things we have to learn before we think we can do them, we actually learn them by doing them. So I'm going to turn that over to Kathy now, who's going to provide a little bit of a more detailed overview of how this works in action.
Sure. Thank you, Todd. And actually, I just love that last slide with the Aristotle quote. And I keep thinking, you know, he was thinking of our collaborative when he just didn't know it, right? He just didn't know it yet. So that national learning community, that slide that you see in front of you here, that really is showing just that we have to learn those things before we can actually do them, and we learn by doing them. So we start with that small population of focus, and possibly how are we doing that? How do we decide just who should get this great care first? Well, you think about who you're the population who's going to be most impacted. Maybe it's those with multiple medications or multiple chronic disease states, but you get that number down to a manageable number, as Todd was sharing with you. And there's a number of reasons for that. One, you are trying to learn a little bit before spreading this on to the greater number of patients, and there's less of a cost impact to the organization as you're going through this learning process. So there's the benefit of that, and the ability to work with that smaller population to ensure they're getting quality care. And you're working with that local healthcare organization and their partners. So you're really out in the community. I mean, this is just you know, more than just one small organization, one small provider. This slide actually shows some of the means that we use. We recognize in this day and age we have the ability to meet folks virtually and provide that training. And I love this slide because this actually was taken from a learning session that we did with the FDA Studios in partnership with the Patient Safety and Pharmacy Collaborative. And it actually shows you, there we are on the screen. And to this day, you could Google this event and you could pull up all these trainings and review this. So it's real time as there's workforce change. So it's really meeting us where we need. That's some of the things that we're providing. The very next slide really is showing you a little bit of the impact. Now at the very bottom, I feel obligated to share with you that there are 450 teams enrolled in the collaborative to date. And this slide is really indicating that it's 111. Those are the ones actively reporting. And when I spoke with Mark Loafman about this, I said, you know, this is really an opportunity, because one of the challenges that we've heard on, and I'm going to be transparent, yes, there are challenges, is that dual data entry. So the great thing, and AIM is currently pursuing a contract, they're actively working towards a contract with a foundation for that ability to collect data that will interface, the actual data collection product will actually interface with EMRs so that there won't be the dual data entry. You'll just extract that data out. So the opportunity will be that we won't have a number of 111 that are showing this average population. We will be able to show 450. We will be able to show 4,000. I mean, the number, you know, the sky is the limit when you get that electronic interface going. So this really does show the number of that we have. This slide here really talks about the scale up and spread and our partnership that we developed with CMS in 2012. They became a very critical partner, bringing in the quality improvement organizations, to which many of you may or may not know, focus on our Medicare population, which is really our highest risk population. So the cost savings, the health savings, just the improvement of life overall the potential with this partnership was just amazing, and we were able to manage great things. This slide is just a slide to show you where to go to get more information. As always, if anyone ever has questions, I know I'm available. Dr. Loafman as well as my co-lead, and Todd as well. So thank you, Mark.
Guys, thank you so much, both of you. It's not fair to you to have you do in 5 or 6 minutes what it took 6 years to build, but I think you did a great job of showing us what really counts and what matters about that. And we wanted Dr. Masterson, who's perfectly aware of this program, but to hear, Colonel Masterson, what you thought and what you thought the innovations are and what might help scale up a little bit. So if your mic is open and you could respond a little bit, we'd like just a quick, quick thought of what you're hearing.
Yeah, I hope you can hear me okay.
Yeah, it's great.
Okay, yeah, Alman and I are just finishing up a talk here at Fort Myer on the Interagency Institute, which is a number of individuals that are emerging as senior leaders within the federal health sector. And I think that the point here that is critical is really how do you get these lessons, how do you disseminate them, and how do you keep people actively engaged? And so there's a certain amount of time that you can develop that trust and those relationships with face-to-face interactions, which are critical, which is one of the things that we often stress with the Health Futures group, is that the importance of getting that connectedness. But to keep the momentum going and to move that net energy forward is you need to keep the impetus going. And so I appreciate the time that you guys have put into these types of venues with the virtual collaboratoriums, because we're moving beyond the abilities now of time and space for people to actually share their ideas, and really it is part of the win-win-win-one construct, which is you have to harvest the wisdom within the network and disseminate that, because in order for the wellness initiative to take hold, to correlate with the wealth and the driving of the prosperity and security of this country, is that we really do need a whole-of-nation approach. And the only way that you're going to do that is by opening up the venues and opening up the forums for people to share their ideas, share their thoughts, and actually institute, whether it be through real-time, real-world connectedness, or whether it's the virtual collaboratorium which you guys have created. So thank you for doing this, and thank you for the presentation.
Great. Thanks a lot, Beth. That's picking up on the, I think the collaboratorium, the virtual learning model was a smart insight, and we're going to call it up, and I'm guessing that Michael captured that on our map probably that we'll be looking at in just a minute. So thanks for that. We're going to jump ahead. As we do that, I want you to take a quick look back at your worksheets, and if you have a second, just jot down some quick ideas, quick thoughts to keep us moving about what the AIM Collaborative said to you, especially in terms of these top two boxes, the breakthroughs and what's ready for scale up. We'll get to request to offers in a little bit when we have a chance to cross-populate some of these ideas. Thanks so much. We're going to jump ahead now with the Healthy Weight Collaborative, and I think Dr. Shaila Serpas on the line from San Diego to talk to us about that initiative. Shaila, are you there?
Yes, I'm here.
Wonderful. Thanks so much for this, for jumping in and joining us here. And I've got your first slide up. We're really excited to hear about this. I know 5 minutes is not fair to tell us, but we just want to hear the bottom line. What's big? What's happening? I'm going to pace us through the slide. So tell us a little bit about yourself and what's going on.
Sure. I'm a family physician with Scripps Family Medicine residency, so involved with resident education for about 15 years. And this collaborative, I'm opening with this slide because it really demonstrates the range of partners that have been involved in the Healthy Weight Collaborative here in San Diego. We have representatives from public health, university, primary care schools, community organizations, and in 2011, when we started this collaborative with HRSA and NICHQ support, there was really no budget, and it required a huge commitment of resources from each of the partnering agencies. So I just wanted to emphasize that aligning the work plans of individual agencies with the goals of the collaborative right from the beginning helped to ensure our sustainability now 3 years later. Just to give you an overview of the strategies, I will not be discussing these in details, but it just gives you a flavor for how we started with creating a common vision and then delved into the detailed work to implement these strategies. Without time to discuss, we do have a publication in the Journal of Healthcare for the Poor and the Underserved last year that talks about the details. So I'll jump to the next slide and show you this strategy map, which really is not intended for you to read in detail, but to get the gestalt of that center focus of the target population, that round blue circle, really shows how geographically we specified in a defined community what our target population, which included a primary care clinic, an elementary school, and an early child care site. And just as you heard earlier by the pharmacy collaborative, that it was very important for us to use a PDSA cycle to test what worked on a smaller scale. This target population was our test round, and we developed strategies you see in the surrounding 5 large boxes that really included all partners, primary care, public health, schools, community, and early childhood. And we used it as much to test ourselves in a systems approach to how could we each work in the strategies and look for new ways to develop interactions between the different sectors. So on the next slide, this is an example of our BMI surveillance data for 24,000 kindergarten through 6th grade students in our Chula Vista district that were measured. Their BMIs are shown here. On the top left, that's 2010, and then the surveillance was repeated in 2012. The green circled is one school that was our target school, and we really tested, as I mentioned, a lot of the wellness policy changes that were coming, which included things like eliminating flavored milk from the cafeteria, using healthy fundraisers instead of traditional cookie dough and such, and requiring non-food birthday celebrations. These were policy changes that were coming district-wide, but we used several strategies in the target school to test and adapt how was the uptake going to be for these district policy changes. So the school really became a model for some of the positive outcomes that we were seeing. You can see that district-wide from the policy changes, the red and the orange are the higher BMI rates at each of the school sites, and 2 years later already we were seeing a trend towards the lighter colors, which indicated about an overall 800 students that moved from unhealthy weights to a healthier weight zone. So certainly we don't have cause and effect here, but we're very optimistic with some of our strategies working. And our target school has really become a bit of a poster child. Even today as we speak, the Clinton team is coming to visit the school. We've had multiple media attention at the school, so really testing on a small scale seemed to really have a positive impact on the success of the district-wide process of scaling up the work and implementing sustainable wellness changes. This whole surveillance process was developed into a toolkit so that it could be scaled even higher to other districts, and that's available and posted on sandiegocounty.california.gov for other districts who want to implement a surveillance project but are not sure how to do that. So I'll move on to this policy changes that really some of our learnings, some of the key learnings from the policy changes that we took away were really including multiple sectors in the process, so our public health partners, our primary care, our community organizations, we all supported the schools wellness policy change, and we tested it on a small scale, and we included a wide collaborative to have a larger impact that our wellness policy could have, so that I really can't go into details right now. But the next slide, I'll just mention that our family medicine residents were involved in this process along the way, really encourage them to be engaged simultaneously in the clinic quality improvement activities, which showed through chart review an improvement in the residents' documentation of BMI percentile and education with families, but simultaneously being engaged, as you see here, in cooking classes and physical education at our target school, as well as community advocacy as they testify at city council meetings to help change the built environment. That this really has an impact on creating the future family physicians to be strong advocates for their community and understand the link between quality improvement within the walls of their clinic to the improvement of the larger community from which our patients reside. So finally, our last slide, I just summarized our opportunities and challenges. Some of these are obvious and faced by many partnerships. Sustainability is key, as I mentioned, in creating that collaborative network in the beginning. Measurement, it's always important to find data and document the progress of your collaborative. We found BMI surveillance data to be very useful. Funding is always a huge need, and expertise and evaluation resources. And then linking these policy to environmental changes. I'll end with a brief story that really helped move our district policy forward when we were testing at the school site and implementing a healthy messaging campaign called 5210. The 0 represents zero sweetened beverages, and one of the children in our school was recorded on public radio as saying, if we shouldn't have sweetened beverages, then why does the cafeteria serve us chocolate milk? And as much as a young child voice can have an impact, that really was instrumental on helping the district move forward in eliminating flavored milk as part of their school meal program. So I'll end there.
Dr. Serpas, thanks so much. It's impressive. We're proud of the work you're doing. We've asked Captain Henry, Dr. Henry, to listen in and share his thoughts a little bit about it. He's certainly interested in the health of our workforce and our services. So, Captain Henry, if your mic is open and you're able to jump in, just tell us again a quick sense of what your reactions are about what you heard that's ready for scale up.
Sure. First of all, can everybody hear me?
Yes.
Okay, great. A little concerned. I'm actually at Walter Reed Bethesda today, and we're just finishing up rounds in the ICU with the interns and residents. And just a caveat in terms of the kinds of patients that are admitted to the hospital, which is a lot different from the outpatient, but relates to the chronic illnesses and diseases. And just as a sidebar, the average age of the patients here in the ICU, which is a census of 14, again, Walter Reed Bethesda, is over the age of 85, even up to 95 and 100. Many of these patients are dealing with chronic illnesses such as the diabetes, obesity, lung disease, congestive heart failure. I mention this because it sort of is a bimodal distribution in terms of the types of patients that are seen on the one end of the spectrum and then the types that are seen at the level that we're discussing here. And yet these patients take up incredible resources. However, nevertheless, you can relate what you're seeing in the at the front line as an outpatient based on chronic illnesses, which will lead to a tidal wave of problems that I will see more and more related to obesity, hypertension, stroke, etc., if we can move forward in terms of healthiness. And the days of infectious disease issues that were common in the 20s, 30s, and 40s and others are long gone, and now we're seeing a much more chronic condition. So with that, I'll just say that we've been talking with the different MHS Innovation POC folks on the Navy side and trying to align our innovation programs that are scattered here and there to see and answer the question, what breakthrough innovations do I hear that are ready for scale to help move our nation towards health and resilience? And again, those innovation ideas from this script can be anything from the front line to a strategic relationship. And just as an aside, I've been gathering what are the innovation and ideas that are being funded and bubbling up through. There's the Integrated Healthy Community Initiative that's being run by Commander Sunny Ramchandani in San Diego that is touching upon these areas, and I know he's working with Scripps and the VA on getting his arms around the high users or those patients that are the hotspotters as per Axel Gwandi's work. And then for process improvements, we have many ongoing inpatient innovations. Again, this is a little sidebar away from here, but at least within internally, Nate Medicine is funding projects to sort of streamline staffing and inpatient services. And then I counted around 9 process improvement programs here at Walter Reed, and I got an email for 4 more at Pendleton that are, again, at the front line addressing everything from outpatient weight loss, stress reduction, and nutrition and eating habits, and even pharmaceutical use. And I'll leave it at that, turn it back over.
That's great. Captain Henry, thank you so much. And I love that you made the connection between kind of the new public health epidemics that we're seeing, also that while Dr. Serpas' project really focused on this adolescent or early adolescent childhood population, model, improvement model, the same one the collaborative for pharmacy is using, applies to many more. So that's fantastic. Thank you for that. Really, really helps. Take a minute, folks, and jot down your thoughts on your worksheet. We're going to keep right on moving. I think we do have Dr. Elenberg from Germany over with us. Is that correct? Am I good?
I'm on the line. I don't know if it's open.
Wonderful. Yeah, we hear you. I'm going to get back up to your slides here. And thanks so much for joining us. I know this is a little bit tricky to tell the great story that you have in such a short amount of time, but I know you can do it. So, Dr. Elenberg, welcome, and let's hear about the collaborative.
Okay, great. Thank you so much.
Demonstration project.
Can you still hear me?
Can you try again? We got a terrible echo there for a second.
Yeah, I'm hearing a lot of echo. Can you hear me now?
That's perfect, yeah. Where are you right now?
I am actually back
Okay.
in the States, so.
Okay, great. Welcome back.
Thank you.
So if you can see the presentation, I've got your slide up on the Healthy Base Initiative.
I can see it. I'm just getting a lot of echo. Okay. So Operation Live Well was based on the concept that, similar to what Captain Henry was saying, overall DoD, we're seeing such a huge surge in chronic diseases that are driven often by behavior or the environment. And so we decided to launch something called Operation Live Well. 65% of our costs, our healthcare costs, are related to chronic diseases aggravated by obesity and tobacco. So those were kind of the low-hanging fruit to tackle first. And we used the National Prevention Strategy and CDC's Healthy Communities to help drive a concept. So we created something called Operation Live Well, and it's a 3-phase strategy to change culture and environment. So the first phase is really an information and education phase. It's informing our constituents what we're doing, but it's also informing ourselves through a demonstration project called the Healthy Base Initiative. We're going to take what we learned during that demonstration and from partners like those participating in the Futures Group to inform phase 2, which will occur about May in 2015, on a strategic plan for implementing healthy communities across the Department of Defense. And then phase 3 will be implementing it long term. And I'm also happy to say that we are working with Captain, not Captain, though he should be, Commander Ramchandani. He's really awesome. San Diego's really leading the way there. Can you go ahead and flip to the next slide?
There you go.
Thanks. We tried to look at different installations that reflected different populations. So we have 9.6 million beneficiaries. We have about 725,000 DoD civilians. And those DoD civilians are just as critical to our readiness and mission, which is defending the nation, as the active service member. They might have different physical requirements, but their productivity and their ability to be well and really be attentive is critical. So we selected 2 Air Force, 2 Navy, 2 Marines, a Coast Guard installation, Guard Reserve, and then we also picked Defense Logistics Agency because they purchase food, and fueling the body is a key component to health and wellness, and Defense Health Headquarters because they need to lead the way. Lastly, we had 3 Army installations, the Fort Sill, Fort Bragg, and Fort Meade. And Fort Meade is critical because that is 52,000 DoD civilians versus 6,000 active service members. And like I said, they're a key component. Go ahead. So what we're doing is we're looking in these key areas, the physical activity, targeting children, schools, and families, and specifically looking at that because it was very effective. When you educate children, they seem to have a strong influence on parents. So this is kind of a pincer move. where we are tackling the adult, but also trying to get to them through the kids. The healthy food options is another area of physical environment, health and wellness, where we're looking at the integrated healthy community and tobacco use. Our tobacco use is much higher than the national average, so this becomes a significant impact on our health and wellness. What you see in pink are different programs that we're offering in those areas, and that's just a sampling. What we learned from implementing the National Response Plan is that a plan won't work. It's got to be contextualized to each community, their needs, their resources. If you think about it, submariners are living in a very different environment than Army folks who have gyms and installations they can go run on. They can't have a treadmill in the submarine. It has to be silent. So how do we give them the physical space and room they need to stay fit? And how do we feed them given that they're underwater for 3 months? So we want to get them the right fuel. So again, that goes back to reflecting a choice for different things that we want to implement, but it's going to be the same framework for each installation. So the Healthy Base Initiative itself is a variable. We're progressing well. You can see here it looks like a little bit of a horse race on where we're at as far as execution. Go ahead, next slide. And this is a little bit of our methodology. So we went out to each of the installations. We did an assessment of their needs. We applied the framework to what they currently had. Wherever there was a gap, we made suggestions for programs that we thought would be helpful to them. We also tried to identify any promising practices so we could highlight those and then share them through a knowledge sharing group across DoD. And one example of that was the 5210 program, which was being implemented in Hawaii, and where it was implemented with children, we saw a reduction in obesity across the board and a change in eating habits. And so now this is going to be rolled out across the Department of Defense as a strategic communication campaign. And then we'll have programs that can be directed at children and programs that can be directed at parents. But that's just a little bit of a guide on that. So there are 22 promising practices that we're evaluating in addition to those programs that we're recommending to the installations. Once those are recommended, the community itself concurs and makes their own suggestions and feedback. Then an action plan is developed together and collaboratively. Baseline objectives are measured, and then we go ahead with implementation. Some of that implementation even includes training from the Culinary Institute of America chefs for things like the people cooking in the DoD schools or in our dining facilities and stuff like that. So you can see on the current slide our timeline, and then that follows through with the second phase of Operation Live Well, which is to take what we learn, and we'll work with key stakeholders, including NACCHO and AASHTO, because 70% of our folks live off the installation, in addition to the Uniformed Services University of Health Sciences. So we can develop our strategic wellness and prevention strategy. And then, as I said earlier, we'll implement this across DoD. As council members of the National Prevention Strategy, we'll share this information as we learn it across the board, because we're going to look at metrics like behavior change, biometrics, as well as utilization data. So we might have some good clarity on what combination of initiatives are effective together. We know it's not a silver bullet, but perhaps a silver buckshot that will really make a difference in the community. And that's all I have. I stand by for questions.
Thank you very much. We really appreciate that. It packed a lot in a short amount of time, and it's a great story. So we've asked Captain Paul Reed, who's familiar with your work, I think, but to really focus in on our question now. So what, Paul, if you're with us and your mic is open, what did you hear that you think's ready for scale-up?
Yeah, I am here, Mark. Can you hear me okay?
Great. Yeah, that's perfect. Thanks.
Okay. So first, I think what comes across loud and clear, even though it may not have been explicitly said, is that the DoD and the Defense Health Agency has clearly recognized and latched on to the imperative that is health. that in order to drive such a large, broadly contextualized effort, and one that truly defines an enterprise effort, to me suggests that the imperative is there, it's well understood, and it's clearly a motivating factor pushing everything forward. Secondly, I think the most innovative aspect to what Kimberly just spoke to, and by the way, Kimberly, it was great hearing your voice. It's been a while. Is in that it is such a broadly reaching effort, one that addresses the entire biopsychosocial spectrum of living and truly gets at what the Army Surgeon General refers to as the life space, and doesn't drill down like we historically have in entertaining that health is really more a management strategy for disease. Those are potent efforts, and to put it at a scale DoD-wide like this effort is intending to do ultimately, I think is more than commendable. And then lastly, and just to keep my remarks brief, having their long-term goal, their ultimate phase 3 goal being behavioral change, I think is a very bold concept indeed. It's bold in that it challenges each one of the Department of Defense's constituents to take individual ownership of their role in the process, but also it challenges all of the various sub-organizations within DoD, and there are many, and their affiliates, their partners supporting DoD, again, to take ownership and to paint that right up front as the ultimate end game for this initiative, I think is, again, tremendous and commendable. So those are my big three. One, the recognition.
That's great. Nice job.
Yeah, I was just going to say, repeat. The recognition of the imperative of health, the broad context for the initiative across the biopsychosocial facets of living, and the bold statement that this is ultimately about behavior change in our systems and our people.
Yeah, it's a new kind of public health. Very well said, and talking about the scope and scale, so I really appreciate that. I want to remind us again about our worksheet, so make your notes here or also on the GoToWebinar question box. Feel free to toss things up there. We're going to have time in just a minute to process what we've heard. We've got one more story, so as Jim Killeen is getting his mic opened up, I'm going to pull back up to his slides, and we'll get ready to hear about that initiative, which is also pretty exciting. Last, not least, by any stretch of the imagination. So, Jim, are you with us?
Yes. Can you hear me okay?
Yeah, I hear you. Great. I'm gonna advance your slides for you, Dr. Killeen, and run us through the Beacon project. We kind of framed this as Beach, Beacon, and Santa. There's so many entities involved, but I know we only gave you 5 minutes, so walk us through this, Jim.
Sure. So here in San Diego, we were awarded one of the Beacon projects from Health and Human Services back in 2010. In which we were designated to beef up our HIE infrastructure to essentially improve care coordination as well as engaging patients and their families. Here in San Diego, we focused on cardiovascular care for the acute care settings, focusing on EKG transmissions from the pre-hospital field into the hospital for those patients with myocardial infarctions, not just to reduce time to catheterization, but also we found that there was about a 30 to 33% false positive activation rate, which we were able to successfully bring down to 0 in multiple hospitals, showing a true ROI, just getting the correct information to the correct person at the correct time. We also focused on chronic care conditions of heart failure, trying to reduce 30-day readmissions with both health coaches as well as devices in the home, working with nurses, getting the correct information back to the providers to prevent these 30-day readmissions. We also focused on enhancing public health data to our partners here in San Diego, as well as getting our partners meaningful use certified for both immunization, syndromic surveillance, as well as electronic lab reporting. We did this through one of the devices I'll speak about in a few minutes, which is our public health hub. And our main goal was for obviously reducing any sort of cost efficiencies for hospitals, emergency department visits, or redundant tests. You go to the next slide. So we were able to create several innovative projects, of which there are 4 core components that we pushed off to an independent nonprofit health information exchange here in San Diego that stands independent with board members that include VA as well as major other healthcare systems in San Diego. Some of those components included the EMS Hub, which I'll speak about in a few minutes, as well as some situational awareness, in which we leveraged ADT messages, which are stand for Admit, Discharge, Transfer messages. Anytime a patient arrives at a health system or doctor's office, they create one of these ADT messages, which can be leveraged several ways, as I'll explain in a few minutes, to notify payers, patients, providers, health officers, and public health officers. As well as now having this population and public health data, we're able to do analytics on this large data set, as well as provide visualization tools for those that can get a better concept. As you know, I hate to use the term, but a picture's worth 1,000 words and 1,000 talks, and it's just very easy to understand once somebody can actually see these visualization tools. We also were able to leverage medical devices that were not only at home but also embedded, such as pacemakers and AICDs, into the mainstream care of these patients. And then we also focused on telemedicine and bringing in this environmental data, which I'll mention in a minute. If you would go to the next slide. So this is our schematic for our health information exchange, in which us is the beach, which I'll explain in a second, but also the health information exchange leverages multiple sets of data within our cloud-based health information exchange. We have multiple connections to multiple partners, including the DoD, the VA, as well as our community partners and individual community providers that care for patients, the dependents of those that work for the DoD. And if you would go on to the next slide. So the beach is really a offshoot of the Beacon project, where we leverage not only our best practices but all 16 other best practices from the other Beacon communities, and we bring that and educate local communities throughout the country that are interested in these best practices and implementing some of these best ideas in their own communities. We do this leveraging the data and using our analytic tools, bringing around situational awareness and providing that infrastructure and education to the different communities. Next slide. So I'll give you an example of our EMS Hub. This is data that comes in real time that's used several different ways by several different users depending on what their job description is. Here's a schematic of how the pre-hospital folks answer 911 calls and provide pre-hospital care before a patient arrives to an emergency room. Here we've partnered with all the different electronic patient care record vendors that provide applications to our paramedics here in San Diego. This data, along with any sort of device data such as EKGs, vital sign monitoring, is all grabbed by their data system and pushed to our EMS Hub, which essentially is an interface engine that we translate this data several ways. One is we provide an HL7 message that can be imported into the hospital's EMR systems, as well as provide a web portal in real time for our base hospital 911 med control center information, so that nurses who are receiving these patients can have a better idea of what they're going to receive. And then we also translate this data for state reporting. Oops, sorry, go back one more slide. So we also report this for state reporting for the paramedics as well. And then also you'll notice down at the bottom this EMS registration. We bring in this ADT information also into the EMS hub because we can marry that with the patient care records. So if you go to the next slide, we've now leveraged case managers in the field for high utilizers of 911 or high utilizers of healthcare dollars to better coordinate their care and bring down some of those costs. Here we use the same data set, providing different sets of information using multiple analytic algorithms where case managers can be notified either by 911 of patients based on name, address, location, or geographic latitude, longitude of multiple users or frequent users, and can intervene when the paramedics arrive. The other method is that the paramedics can also notify the case manager, hey, we've got another one of our John Does here that's a frequent user. And they can intervene in the meantime and prevent these emergency department visits and high utilization of healthcare dollars. Now, I'd like to go to the next slide. And what we've done is, having this data set and with the population and public health data that's reported from each of the health systems, we're partnering with our public health partners, such as Bela up in Solano County and our folks down here in San Diego, where we can notify the ambulance folks that there is a communicable disease that they're going to based on latitude and longitude from a query that's done from the 911 call that's sent to the public health hub, and then back to those providers before they even reach the scene to say, hey, you need to have extra precaution for this communicable disease. So we're sort of pushing the envelope for that next stage of analytic information that's available with the data that is used in everyday care of patients. Next slide. Sorry, next slide. There we go. Okay, all right, so another one of our projects that we are also pushing out is, oops, go back one, is our asthma project.
There's a delay, I think. Sorry about that.
Okay, no problem. Where we can actually bring the power of the data to the individual. What we did is we took asthma patients from primary care doctors that said, hey, these patients are having asthma difficulties and are somewhat savvy and have a smartphone. We then paired the Propeller Health MDI counter, which is a wireless counter that gives latitude, longitude, and timestamp of when they use their inhaler, as well as the device below it called CitySense, which measures air quality where the patient is. And we took that data, both of those sets of data, which are Bluetoothed into the smartphone, pushed those off to our Azure cloud, where we can do analytics off of this information. And we're able to present this data back to the patient using direct messaging, so it's secured patient data. And the patient can actually look at that data, figure out what they have done or where they're using their inhaler more frequent based on the environment or their activity, and then also push that to their primary care physician, where they can then change their care plan based on either their location or their activity of what they're doing to better impact their health performance and need for the medication and need for continued visits to the doctor's office. There we go. So what we did in our Azure Analytic Cloud is that we broke down the data and married both the device data with the environmental data, presenting two different graphs here, as you can see. One on the left, which shows a much more detailed breakdown of the particulates that were measured from the CitySense device. So you can get your carbon monoxide levels, your ozone levels, and see if that's actually causing any sort of impact on the patient individually. We then broke it down into a much simpler graph just giving a summary for the primary care doctors to say, okay, what's the air quality and how frequently are you using it, and can we tell, where you are based on the graph below, what sort of environments were you in that you had to use your inhaler more frequently, and see if we can't do some impact change there for the individual. And again, this data, which comes by direct messaging into the patient's personal health record, is then pushed from the personal health record back to the provider. If you go to the next slide, using the link below, we actually created a visualization tool. Next slide. Where the provider can actually see where the patient was using the yellow data. That gives the air quality of where they were, which collects every 6 seconds back to the server and does some analytics off of it, as well as the red tags, which show when they were using their inhaler. And we can actually get a visualization tool of, were they actually behind a bus when they had to use it? That sort of configuration within time and space. So this is a new sort of avenue of geo-health that can be applied to the patient for better care of their asthma. And this next slide, what we did is we're now, as with GeoHealth and our situational awareness with 911 information, we can actually look from the 911 call all the way through the event, from emergency visit to admit to discharge, and actually get that entire longitudinal view of what happens to the healthcare event in the patient. So we can look for patterns, especially here in San Diego, or of course essentially more in Los Angeles with the smog. You can actually track cohorts of patients now based on and we're also looking now at within this 911 data as far as suicide or overdose prevention, based on chief complaint that's entered by paramedics. We can actually track patterns of suicide or overdose preventions, especially because we're a large military community here. The post-traumatic events, PTSD and depression is hard for most of the vets, and so we can actually pattern and have some
unmuted
care of these patients. And so that's not only what we have in use, but also where we're moving to. And with that,
I know that it's a lot of great information, and it's a lot to present in a short time. You did a good job of whetting our appetite for what can be done with technology. And again, our goal here really is to sort of extrapolate what about that translates to spread across. So we've asked Dr. Calvo, who's familiar with your work, but also understanding the context of this question. So Dr. Calvo, I hope your mic is open and you can respond to our question. Yes, we can hear you.
Okay, so my response is, what we've heard so far from, say, the PSPC was team care and person-centered work around that. The healthy basis around facilities. Shaila talking about the Healthy Weight Collaborative and public health and policy implications. And what I hear in the possibility of what just was said about the beach beacon, etc., is the notion of we already have all the pieces to connect up all of those levels from the earlier presentations. In other words, we in essence can take dollars from HHS, dollars from DOD, dollars from other entities that have already been funded, and connect them up. In other words, the communities of practice, the communities of solutions being connected up through IT and people systems, allowing us to take these pockets of excellence and connect them up in national dissemination for local action at the community level. In other words, we just have to think about all of this as being able to be connected. There's no reason that these programs should be entirely thinking of themselves in isolation. We need to bring all of that together at the community level to really respond to Shaila's request for funding. It's just that people have not been thinking about taking the dollars from Office of National Coordinator, for example, for the beacon and connecting it up with a local entity in San Diego that's already got money from HHS with, say, Commander Sunny at the Navy, and connecting that up as a help to the Healthy Base or the Healthy Community effort. That's what I heard in the latest presentation, because the IT stuff is already in existence.
Brilliant. I mean, you really spoke right to our theme for this webinar, connecting communities of solution, looking for synergy and alignment, and exactly what you talked about. Together, we can do this. Working at the enterprise level and at sort of that scope to solve these wicked problems. So we're going to jump into now. I'm going to turn the screen over to our colleague, Dr. Michael Knowles, who's sort of a master at mapping conversations. This is a screenshot of the map we started with a few hours ago, and I'm sure it's already gotten bigger. So Michael, if you're ready, you can take from me or and start driving.
Can everyone see can you see my screen, Mark?
I've got it. Yeah, I see it now.
Good,
yeah.
Okay.
And I do want to, as you're getting that pulled up, I want to thank, really thank our 4 presenters, our communities. It's just really unfair to ask them what we asked them to do, and they did a great job. And it's a smart audience, so we knew you could glean a lot more from what they said than the time allowed. But let's get started with the conversation. We want to open it up a little bit to those that are ready. You can raise your hand. Mr. David Price is monitoring that and is going to see that you've raised your hand. You're ready to talk. And as you're getting ready to put your hand up to speak, Michael's going to walk us through the map that we have developed so far. Michael?
Yes, Mark, I'm going to do that. We've heard from several folks today in the map, and as you can see, basically this is just a very simple visual representation of the feedback from folks we've had so far, opening up venues and forums for people to share their ideas and thoughts through collaboratoriums, which is a great way to share across geographies and time zones from the front lines into the strategic relationships forming there, harvesting the wisdom within networks. We're seeing new public health issues that are being addressed by these innovations and breakthroughs for resilience. It's encouraging, too, that the Department of Defense and the Defense Health Agency have recognized and latched on to the imperative of the nation's health. The Healthy Base Initiative, for example, a broad-reaching effort that embraces the life state itself. Team care and person-centered work. We've been talking about facilities, and I think Ahmed really said it well when he mentioned that we have the pieces to connect the 4 communities of solution for national dissemination at the community level, and that's what HCCA is about. So let's see what other questions we've got, and go through there. I think the first question we have here is the Healthy Base Initiative focus seems to be on weight and tobacco. Is there a plan to expand to include alcohol and sex issues?
Yes, thank you, Michael. That question was from Sharon Jankowski. And Sharon, if I open up your mic for you, I wonder if you'd like to just address that. I think it was a question for Kimberly.
Yeah, it was just looking at the slide. It seemed like it was a good start on wellness, but I remember from my master's in health administration and policy courses, they did tend to focus a lot just on stop smoking, lose weight, but they didn't look at the other health issues, sex abuse, rape, unwanted pregnancies, STDs, alcohol abuse, and the poor choices that are made along with that. So.
They're really speaking to that comprehensive scope and scale, and I know the Healthy Base Initiative is looking down the road at that, but is Kimberly able to talk to us about where they are with that and what they need to scale that up?
Kimberly, I've unmuted your microphone. Yep.
So we want more.
And alcohol use are really reflective of underlying issues that are expressed in many different ways, whether it's anger, aggression, alcohol use, prescription drug use, et cetera, et cetera. So what we're really looking at is a total force fitness, and we've developed a tool to assess people's social, physical, environmental, medical, and dental, their spiritual, like their perspective, core values, identity, their meaning, their purpose, nutrition, their psychology, their ability to cope and be aware, and behavior. So there's 8 domains of total force fitness model, and that's what the true focus is on. We're just looking at how it's being exacerbated through tobacco and alcohol, given that those were ones that we could have achievable metrics to really see what direction we're headed in. But it doesn't mean we're not focused on the other areas, or that we'll be moving more into those areas.
Very good. That's helpful. Other thoughts about that and other communities? I know, Kathy Baldwin, you've been listening in to what the other folks have offered up there, and I bet you can see several places where there's alignment with what the Pharmacy Collaborative is trying to do.
Well, actually, Mark, that's really a great point. That's actually the immediate thing I see, that we're all doing the same thing, and the overarching goal, is the healthy, the healthy state of our nation, if you will, because that's what I'm seeing. Whether it's pharmaceuticals, whether it's BMI, I mean, we all have that same overarching goal. So the principles work, the philosophy works, the distance learning, some face time works. It all just works.
How could you see, how would you see these starting to align a little bit in terms of maybe some teams being able to adopt or pair up with some of these projects? Would that be a reasonable next step?
I think so, and I think looking at the measures, one of the things we always talk about are composite measures. Maybe the composite measures needs to pull a little bit from each one of these to become its own set of composite measure. It might have a medication issue to it. It may have something to do with the healthy weight or the healthy base or the activity level. I mean, I could see a number of things.
So with composite, you mean really comprehensive?
Comprehensive, yeah, right,
that's
right.
Perfect. Yeah, we look at composite measures, but you're talking about.
And we think about it one way, but this is a whole other way, right? Mm-hmm.
Very good, very good. Would you be willing to commit to the AIM Collaborative joining up if others are interested in doing some work afterwards, a breakout on partnering?
Oh, absolutely, absolutely. I think this is where we need to be as a nation, and even as our AIM Collaborative, but even bigger as a nation. So absolutely, I am wholeheartedly committed.
Very good. Kimberly, does that sound like a fit there? If we set up a breakout and put you guys together to start to look at cross-sharing ideas?
Cross-sharing ideas is always good.
Okay, perfect. That's one tangible. Who else has
Mark, I wanted as well. Yes, Mark, I wanted as well about Jim's perspective on synergy and alignment as well.
Yeah, Jim, you got to listen to everybody else before we put you on. So, I wonder your thoughts a little bit about where you see your technology breakthroughs, which really are very inspiring, fitting with some of these other collaborative efforts. So your mic is open now, Jim.
Well, it would be nice to, I mean, one of the things that we love to do is harness existing technology and just look at it from a different view. I think that certainly is one of the major goals. I mean, in the 3-year period that we were doing the Beacon Grant, we were able to break through the barriers for doing joint projects with the DoD, recognizing that the majority, or I would say almost 80% of their staff or active military folks work and live in the community, and so by sharing that data, they were able to open up better care for these patients, both in the community as well as in the DoD hospital facilities. So I think it's just the collaboration that's the best part of what's there.
Perfect. So if we pull out a breakout group together, you're in, it sounds like.
Yes.
Wonderful. Wonderful. Colonel Masterson, I see your hand up. I don't know, is that for current or from before? So we can open your mic up and give some thoughts about what you're hearing here.
And look, there you go.
Actually, I just wanted to make a quick comment with Kimberly and and Shaila online as well as Jim, is that I appreciate David, you making the connection with Esther Dyson. I just got an email from them and the hiccup as well. So that healthy initiative that they're doing needs to be linked with these types of initiatives. So that's a community-based initiative. And for those people who don't know Esther Dyson, she is basically working the issue with a health prize or X prize equivalent. Her two passions are space and health. And so, David, do you have any update on Esther and the involvement with Hiccup?
Yes, thank you, Colonel Masterson. So the Hiccup competition is launching, and at the moment they're looking for the applications for 5 areas, populations around about 100,000, relatively isolated, so that they can work with clean data. And I think that Esther's in contact with Kimberly about exploring whether one of the bases that we've looked at in the Healthy Base Initiative might be a suitable candidate for that, either the base or the community around it. And obviously anyone else listening into the call is very welcome to suggest or put forward their own communities in that context too. At the end of the webinar, we'll be giving details of our online spaces, and you can find out more information about the Hiccup initiative and all of the presentations today on those online spaces as well.
Very good. We've got lots of good opportunities that just percolated out of this and talking for a few minutes. So let's call up a few more. I know there's, I'm looking at the list of panelists, and there's a lot of brilliance here.
We have a couple of questions coming in.
Okay.
One is, Jim has described the possibility of setting up a health data utility. Is Leo Selly on the line from MIT to talk about how Santa is training the people in these distributed locations?
I see Leo. Let's open up his mic.
Yeah, will do. Got it. There you go, Leo.
Hi, yes, I'm here. Can you hear me?
Yes.
Thanks for calling in.
Yes. I actually wanted to talk about the other project that we're involved with as well, which is PhysioNet and Mimic, which is a data repository that would connect data coming from different sources. Because I think the elephant in the room in healthcare is that we still don't have individualized recommendations. So, I mean, we could engage the patients as much as we want, but the evidence for a lot of the things that we're doing is a bit flimsy. And that's really the reason why we're heavily involved with data analytics, and these are usually data that are routinely collected in the process of care to be able to come up with personalized recommendations by analyzing that data. And we could provide that platform for the different organizations that are involved with collecting data and sort of open up that data to researchers. So we have been what do you call this, providing a rich ICU database coming from Beth Israel, which we have de-identified, and it's available really for free to all investigators around the world. With right now we have more than about 2,000 researchers who are actively performing analysis of that data, and I think we really need to do that to be able to improve outcomes, whether they're in the ambulatory setting or whether they also involve acute care. I think we need to address all the information gaps to really come up with recommendations that will improve outcomes. But Sana is really involved with providing a cell phone-based platform to collect the data so that you don't even need internet connectivity. And that is interfaced with a back-end electronic medical record system. And of course, we would like to interface that with other sources of data, including the non-traditional clinical data. So we think that there's a lot of information that could be gathered from data that we don't normally look at as clinical. And I think that's really going to be the future of medicine, is to be able to connect all the dots together, linking the clinical data with the non-clinical data to come up with sort of better systems of care.
Leo, that's very appealing. I mean, thinking about, from a provider perspective, how, standard benchmarks just don't fit individual patients, and the guidelines are meant to be individualized. So I think you're describing a way that patients can really be empowered to help affect and influence the care that's provided for them, and to maintain a healthy environment rather than waiting until they crash and burn and the system suddenly becomes interested in them. So very compelling. Would Santa be willing to, if we do some follow-up breakouts, to jump in with us? I think clearly there's a connection with all four of the communities of solution we described here today.
Definitely, and we could, what we can do too is to provide students. So what we do in our projects in other countries is that we connect the local health organizations with engineering students from the local university as well as public health students, and they're all looking for real-world projects. So that's what we've been doing in Uganda, in Colombia, is to provide some free labor to build the technology platform for this quality improvement projects.
So we could actually have a real laboratory in a global environment where students from MIT partnered with some of our faculty and team with people on the ground in that global environment to pilot and test on a small-scale projects and then scale them up. It sounds like that's not only doable, but you're already doing some of those things. Did I get that right?
That's correct, and we're replicating it in different parts. So, for example, the project that was started in Mongolia is being trialed now in Tunisia, and this is like a teledermatology project. So there's a lot of capacity building, sharing of experiences, trying to come up with better practices in implementation and in scaling.
Brilliant, brilliant, very exciting.
Thank you, Mark. And we have one question, perhaps the final question, given that we have about 5 minutes to go, from Susan Hull. Susan, I'll just unmute you.
Susan, it's great to have you on board, and we worked together in Team Hotel back in Roundtable 3. So how are you?
Actually, Mark, it looks as though Susan, because she's dialing in on the phone, might not be able to ask the question directly. So I have her question. Okay. So Susan, if you'll forgive me for asking it on your behalf. Go Susan ahead. Was asking...
Susan is unmuted.
Thank you. Susan, go ahead, please.
There?
Oh, thank you, Mark, and what a great session today. I really love how we're bringing these different data sources together, particularly to help providers make sense of our health, wellness, resilience, outcomes, and in a much tighter cycle for intervention. But I'm wondering what we can do to look towards more transparency to consumers. And so thinking about the sense-making needed for consumers for their individual health and then their contribution to the health, wellness, and resilience of their communities. So it's kind of a both and, but thinking about developing tools that really reach out for sense-making on the consumer and patient side.
Thank you for speaking that. I think it's important to keep that voice in the room, and I think we're implying a little bit of that with the handheld personal devices that patients would have it, but we have to be careful not just to use that as a vehicle for us to manipulate that data. So well said. I'm glad that's on the map, and thank you again for joining us. I'm going to take us over to Colonel Masterson and ask him to wrap us up and leave us with kind of the big ideas he heard, a little bit of hope for our aspirational future. And next steps will be, stay tuned. Based on what we've done, we're going to map this and debrief and come up with what we think the high-yield breakouts are. So, Colonel Masterson, can you take us out with concluding thoughts and what you heard today?
Yes. Can you hear me okay, Mark?
Yes.
Yeah, what I wanted to do is first thank all the speakers and the reviewers today, and for everybody that's contributed and come online. I appreciate the efforts, and this is really a novel approach in the way to keep the team engaged and moving forward. And particularly, I want to thank Mark for all your work coming in from Chicago, and David from England, and Michael from Carolina. I think that those three really have done just an amazing job to make this happen, and Mark, you've done a great job with keeping things flowing, so thank you very much for doing this.
It's been a pleasure. Thanks.
I think that the big key saying here, and this is what Ahmed and I hit with the Interagency Institute today, is the importance of health as that national strategic imperative. I think everybody is talking about the goals here and what we need to be doing, and we really do need to understand how to influence the national dialogue, because that dialogue then does lead to the call for action. And it's only through the action and the repetitive actions and making better choices that we move this nation forward in the health movement, with the ultimate goal of making this nation the healthiest nation in the world, because it's through those things that we're going to be productive, that we're going to be able to be having that wealth and security that this nation deserves. And so I think that I appreciate the work that the group is doing and continues to do. As I'll stress, as always, Ahmed and I have been working this with all sorts of people, is that it is the health and well-being of the nation, but it must start with the individual, and in order to go to the nation, it must go through each and every one of our communities. And so we cannot get there without that support of the whole of nations to get this done. As I mentioned, this type of knowledge sharing and learning how to apply it appropriately and in collaboration with others is the basis for creating the wisdom for the nation when it comes to the wealth and health and well-being. So, as again, I wanted to just say that this dialogue is important. Please continue to work through that. A couple of things that just really struck me is I really do appreciate people taking that total force fitness and really, and I think that it's also important that we as a group put this on the agenda for the National Academies of Science as well. There's a number of initiatives with the IOM as well as the National Academy of Engineering to really move this agenda forward in collaboration with not only the federal agencies but also associations, industry, and academia. So please stay engaged with that components as well. They are really taking the initiative to heart. You guys are the champions. You guys are on that frontier, and I appreciate the effort that it takes to be a change agent in a nation as great as ours. So thank you and have a great day. Appreciate all the hard work. Thank you again.
And Ahmed had a quick comment as well.
Yeah, comment. You can close this out, sir.
Yeah, just briefly, I wanted to add that we already have the change package from the PSPC, the change package from the Healthy Weight Collaborative, all the tools and insights both for policy and for practical change that might be of real worthwhile exploring further detailed analytics on. In other words, coupling up SANA and the Beacon and Beach to the combination of, if we think of grafting the PSPC change package and all of those components to the Healthy Weight public health change package components, essentially you end up with a larger set of change package components, all of which can be thought of as a large sort of recipe book in a sense of what might be possible interventions that local communities can think about activating at the local private-public partnerships.
Wonderful.
The trick is in connecting this up with data so that we can really sort out what are the most leverageable ones. And that's where connecting up the Beacon, the Beach, and the SANA to all of this gives us that connectivity for good evaluation. It's really bringing the academic perspective to bear using modern evaluation techniques. And by that I mean small population sample methodology as opposed to traditional large randomized controlled trials. Anyway, the point is all of these things analytically can be done. We don't have to reinvent the wheel in many cases. We just have to validate the stuff that's already being done in really many places in this country. It's just never been thought of as being combined this way in a massive national scale all at once.
Yeah, this meta collaboration, you described it well, and it speaks to why we brought the 4 communities in that we brought in today. So thank you for those great inspirational closing comments, Colonel Masters and Dr. Calvo. Thanks to all the attendees and all the participants. Great job, everyone. And stay tuned. We're not done. We've got our charge, and we're going to go to work. So thanks again, and take care. Bye-bye.
Thanks, everyone. Bye-bye.